We'll get started just a few minutes early. This is our Aortic 2 session, and we'll start with the impact of aortoiliac tortuosity in outcomes of fenestrated endovascular aortic repairs.
Good morning. Thank you for the opportunity to present today, and thank you for joining us. These are our disclosures. Aortic and iliac tortuosity has been described as a predictor of technical failure, endoleaks, and reinterventions in patients following endovascular aortic repair. And this is thought to be due largely to a decrease in the stability of the endograft fixation mechanism, as well as inadequate seal. In 2002, the Society for Vascular Surgery published reporting standards for endovascular aortic aneurysm repair, and they presented the aortic and iliac tortuosity indices. These are ratios between the center lumen and straight lines between two anatomic sites. For aortic tortuosity, these are the lowest renal artery and aortic bifurcation, and for iliac tortuosity, these are the aortic bifurcation and common femoral artery. The tortuosity index has not been described in physician-modified endografts, and data surrounding the effect of tortuosity on our patient outcomes is limited. Therefore, we aimed to evaluate the effect of aortic and iliac tortuosity on patient outcomes following physician-modified endografts for our patients undergoing juxtarenal aortic aneurysm repair. All of our patients treated with physician-modified endografts for juxtarenal aortic aneurysms over a 10-year period were included. All of these patients were under a single physician-sponsored IDE. Tortuosity measurements were based on preoperative CT angiograms. Demographics, comorbidities, and outcomes were compared. We assessed central-luminal lines and geometric distances using our TerraRecon software. The tortuosity indices were calculated both for aortic and iliac tortuosity, and 3 reviewers analyzed all our patient charts and imaging. Inter-rater reliability was assessed, and we noted that to be 0.9. We stratified aortic and iliac tortuosity using SVS reporting standards, and we defined low tortuosity as those patients with an index under 1.15 and high tortuosity as patients with an index over 1.15. A total of 135 patients underwent a physician-modified endograft, and the aortic and iliac tortuosity outcomes are below. 28% were noted to be in the high aortic tortuosity group, and 41% were in the high iliac tortuosity group. Patients with high aortic tortuosity tended to be slightly older, and 61% of them were male. Similarly, patients with high iliac tortuosity were also slightly older. 89% of them were male. And compared to low versus high iliac tortuosity, our patients differed in rates of coronary artery disease, hypertension, history of a prior CABG, and smoking status. We analyzed clinical and anatomic factors such as indication, rapid growth, diameter of the aneurysm, presentation, ASA class, and prior EVAR, and noted that those patients with low versus high aortic tortuosity showed no difference. And this was similar for patients with low versus high iliac tortuosity. Patients with high aortic tortuosity had slightly longer fluoroscopy times compared to patients with low aortic tortuosity. All other procedural factors such as operative time, contrast use, blood loss, type of anesthesia, and number of fenestrations did not differ. And patients with low versus high iliac tortuosity did not differ in these procedural factors. We looked at outcomes including mortality, complications, spinal cord injury, reinterventions, and endoleaks, and noted that patients with low versus high aortic tortuosity did not have a difference in these outcomes. However, patients with high iliac tortuosity noted to have higher rates of reintervention and any type of endoleak. We then looked at our endoleak outcomes closer and noted that patients with high iliac tortuosity had a significantly higher incidence of any type of endoleak, and particularly a high incidence of type 3 endoleaks. We built a multivariable model adjusting for important confounders including age, sex, history of CAD, and smoking, and noted that patients with high iliac tortuosity had an increased odds of type 1 and type 3 endoleaks as well as reinterventions. From our Cox regression and Kaplan-Meier analyses, we confirmed again that aortic tortuosity, low versus high, did not confer a difference in freedom from reintervention over time. But notably, patients with high iliac tortuosity demonstrated a decreased freedom from reintervention compared to patients with a low iliac tortuosity over time, and these curves diverge early on in our study period. In conclusion, patients treated with physician-modified endografts for juxtarenal aortic aneurysms, iliac tortuosity, but not aortic tortuosity, is associated with increased reinterventions, endoleaks, and particularly type 1 and type 3 endoleaks. We believe that long-term follow-up is critical for these patients, and high iliac tortuosity is important to ensure that high-risk endoleaks are identified and treated early so we avoid complications and risk of rupture. Thank you.
I think that's a great presentation. I have two questions, actually.
Absolutely.
Now that you've identified iliac tortuosity as a risk factor for reintervention and endoleaks, do you counsel patients specifically on this as part of the preoperative planning?
In general, we talk to our patients about the possibility of reinterventions, particularly with our physician-modified endografts and our branched and fenestrated endografts. We always make sure that they understand that reintervention and long-term surveillance is critical to good outcomes. I think with this data, it's relatively new, but it gives us a lot of more evidence to be able to have that discussion with our patients.
Sure. The other question that I have is somewhat more detailed, I guess, depending on the individual patient. But now that you've seen an increase in type 1 and type 3 endoleaks in those patients with iliac tortuosity, do you anticipate any changes to the technical nature of the procedure itself, trying to correct for this in the future?
Yeah, I think most of our endoleaks, I think, were driven by type 3 endoleaks. I think that immediately we traditionally perform our completion angiograms. I think that we would be a lot more diligent with surveillance and making sure that we evaluate for the possibility of type 3 endoleaks, specifically when we don't have SAC regression early on in our patients.
I just have two questions. One, can you comment on any potential selection bias that went in up front? I mean, if someone's aorta looked like a pretzel, they probably wouldn't get a PMEG. And then sort of along those same lines, have you looked at maybe a different threshold? Because maybe if you put that bar a little bit higher, more tortuosity in the aorta, you might actually find a difference, and maybe it's just a matter of figuring out where that threshold is.
Yeah, thank you very much for your question. I think there is probably some bias that we're unable to account for in terms of who was selected for a physician-modified endograft during in our IDE. I think that we do have a criteria for selection for these patients, but we probably are unable to account for that in our specific study. In terms of how we split up our high and low tortuosity, we did do a couple of different methodologies to stay within the SVS guidelines in terms of how we stratified tortuosity, and it didn't really seem to make a difference within our cohort of 135 patients.
Sarah Zettervall, University of Washington. Two comments. Great job, Nellie. One, I think when we're kind of talking about selection bias, I think one of the things you notice in the study is there actually isn't a tremendous amount of aortic tortuosity in this patient population. And that is because I think we have a higher or a lower threshold to say, you know what, there's a little bit more tortuosity. We don't want to consider that a perfectly healthy neck, so they're not going to have as good of outcomes. So then we will move them over to the IDE with full coverage and branches and be able to do it that way. So I think that may be some of the explanation for why aortic tortuosity is not significant. The other thing I would say from a technical standpoint, we have not changed our practice, but I think one of the things you can think about if you have more tortuous vessels to improve your stability is putting those cuffs on there, for if that's something you're dealing with. I think that's another way we can address.
I just have a very quick question. Curious if you looked at if they had both aortic and iliac tortuosity and if that changed things.
These patients were evaluated for aortic and iliac. They are the same cohort of patients. We did not create a model where we looked at both, but that's a very good suggestion.
Okay, I think we're going to move on to the next paper. Thank you very much. Nicely done. Next, we're going to invite up Dr. Faraza Daghi, 40 years single institution experience with secondary aortic and enteric fistulas.
Good morning, and thank you. We have no disclosures. Traditionally and even recently, mortality for patients following secondary aortoenteric fistula repair has been reportedly high, 30% at 30 days and 46% at 1 year, most recently in a study in 2021. We sought to assess the outcomes of patients who presented with secondary aortoenteric fistulas, as well as comparing the patients based on outcome as far as the index open versus endovascular aortic reconstruction they had undergone. We conducted a retrospective review for patients between 1980 and 2021 and utilized the electronic medical records, Social Security death index, as well as an accurate database for data collection. Between the states, we had 85 total patients with a mean age of 70 years, and a 78% portion of the patients were male. On the right side of your screen, you can see a chart demonstrating 5-year increments with the index open versus endovascular procedure, the open procedures in blue, and endovascular in orange. In our study, we demonstrated no difference in the statistical difference between patients with respect to demographics between the index open versus endovascular groups. However, the index open patients were more likely to present further from their index procedure, 102 versus 53 months, as well as symptomatic signs of GI hemorrhage for upper or lower. With respect to intraoperative procedure, the conduit of choice for all of the endovascular patients was an in situ reconstruction and most likely to be using a cryopreserved allograft. However, in patients undergoing open procedure, we again had a predisposition for in situ reconstruction with only 15% being extra-anatomic. However, more likely to be a rifampin-soaked Dacron, 63.2% of overall patients. Patients in the open cohort had a near equivalency between total and partial explantation or excision of the graft, versus the endovascular patients had 88.2% total explantation. Bowel repair was similar between the two groups, with primary repair being most common in 80% of the open and 88% of the endovascular patients, and resection in 17 and 11% respectively. However, perioperative mortality was notably different between the two groups. It was 8.2% at 30 days for all patients undergoing the repair. However, for index open repair, it was 10.3% versus 5.9% in the index endovascular. Notably as well, the repairs conducted after the year of 2000 was 4.5% versus 21% before that time. Complications postoperatively that were non-fatal included the ones seen here, were statistically significant for acute kidney injury and being more common in patients with an endovascular index procedure. However, this was not notable for the requirement of dialysis after the procedure. Long-term survival is demonstrated through the Kaplan-Meier curve seen here on your left side of your screen, with the index endovascular repair in teal and the index open in orange. Notably, the median survival for all patients in this group was 5.6 years. Index open was 4.9, index endovascular 5.7. The mortality or the survival at 1 year was 94% for the index endovascular versus 78.8% for the index open. In conclusion, patients who underwent index open repairs were more likely to present symptomatically with signs of upper or lower GI hemorrhage and present longer time period from their index procedure. Additionally, 30-day mortality in these patients treated after the year of 2000 was seen to be significantly lower than those that were treated beforehand. Thank you.
Very nice. We opened up questions from the floor. In the meantime, I just have a quick question. I mean, it's a small cohort of endovascular, 17 patients, but especially given that you have a higher incidence of renal complications postoperatively or perioperatively, did you look at suprarenal versus infrarenal fixation in the endovascular group and how that played into this?
That's a great question. I don't have the information as far as which type of graft was used for the endovascular group, but that would be a great thing to look into if it was suprarenal fixation.
I mean, certainly when you explant them, if you're going to try to do a total explantation, the suprarenal poses a whole special challenge with some techniques, and we're not to infrequently leave the barbs behind, but I wonder if that factors. The other question while we wait from the floor is about infection. Many of these patients present with an infection. There is this sort of aortic fistula that can sometimes cause almost a pocket of pus, especially in the endovascular cases, and how you manage that. And did you look at the presentation time to when you did the definitive procedure?
I don't have the presentation time for any infectious etiology until the time of the repair reconstruction. We do have information as far as persistent sepsis as well as the treatment that was performed afterwards. And there was no statistical significance between either the endovascular or open group, but that was something that was notable.
Similar to Dr. Maldonado's question, when you look, it's an impressive series, especially with the number of patients and the chronicity of it all. I know you didn't look at necessarily suprainfrarenal fixation, but along the same lines, did you have a chance to examine, because open conduits really haven't changed that much in 20, 30 years, but certainly the graft material deployment, all sorts of factors have changed among the generations of endografts. Did you have a chance to look at perhaps the chronicity during time periods of different endografts placed?
Oh, as far as from the index procedure, I haven't seen from the index procedure. We have it split up by when the actual repair was performed, but to see when the actual graft deployment was and which iteration or series of graft, we don't have.
Okay, thank you very much.
Thanks.
Next, we'll hear from LSU. Dr. Toulos will be presenting vascular complications secondary to reboa placement at a level 1 trauma center.
Good afternoon, and thanks for having me. Our team does not have any disclosures. Resuscitative endovascular balloon occlusion of the aorta, or REBOA from here on out, is designed to manage severe hemorrhagic shock. Popularized in medical care during military conflict, the concept has emerged as a life-saving technique that is utilized throughout the United States. But data is lacking on the risks of REBOA placement, especially related to vascular injuries. Our goal was to assess the incidence of vascular complications associated with REBOA placement, identify risk factors associated with these injuries, and the mortality rate of these patients at our institution. We performed a retrospective cohort study of all trauma activations who underwent REBOA placement between September 2017 and June 2022. The primary outcome variable was the occurrence of a vascular complication related to REBOA insertion or use. Secondary outcomes studied were limb loss and mortality. Appropriate analysis was used per the variable type. Of the 15,866 patients that presented as trauma activations, 0.6% had Reboa placement. And of these patients, 12.1% had some type of vascular injury from Reboa placement or use. The mean age of all our patients was 43.1 years, and most of the patients were male. Our mean BMI was consistent with being overweight. Most patients experienced blunt trauma and arrived during the PM hours. Only 23.2% of patients who had a Reboa placed had documentation that it was performed under ultrasound guidance. 4% of all patients had cut down with their Reboa placement. In our institution, trainees did the majority of Reboa placement, and in the injury group, trainees placed 7 of the 12 Reboas. Again, 12 of the patients, or 12.1%, had a vascular injury or complication related to a Reboa placement or use, with the most common being local vessel injury. 11 of the 12 patients required some form of immediate intervention. As we can see here, most of the patients had a thromboembolectomy or patch angioplasty. And once the injury was identified, the mean time to the operating room was 3.7 hours. Most of the interventions at our institution were performed by vascular surgeons. 7.1% of all patients had amputations. 2 of those patients had injuries from Reboa insertion or use, but all patients' amputations were due to tissue loss that was secondary to their traumatic event and not the placement of the Reboa. 7.1% of all patients were placed on dialysis during their hospitalization, and 1 of these patients had a Reboa injury. None of these patients had dialysis due to prolonged aortic occlusion, but due to rhabdomyolysis from their traumatic injury, or they had a nephrectomy coupled with hypotension and hemorrhagic shock from their traumatic event. 59.6% of the patients lived, and all patients had a mean follow-up of 51.8 days. 40.4% of all patients died. 33.3% of patients with a vascular injury from Reboa placement or use died. The deaths in these patients were contributed to sepsis, hemorrhagic shock, and traumatic brain injuries. Death was associated with many different variables that you would expect, like vital signs on arrival, injury severity score, and the amount of blood products received. But what was not associated was injury from Reboa placement or use. Reboa injuries were associated with laterality of Reboa placement and the type of transportation that brought the patient to the emergency department. Even after adjusting for age, GCS, and ED vital signs, an injury from Reboa insertion was still not associated with death. So an ongoing debate in trauma surgery has been, should Reboas be used or not? And while our patients had a high mortality, the data here shows that from a vascular surgery standpoint and from a vascular injury standpoint, that it does not negatively affect these patients when it comes to mortality or their limbs. While there are case studies that do show that there have been limb loss associated with Reboa placement, in all our patients, their limbs loss again was directly related to their traumatic event and not the Reboa related injury. So in conclusion, vascular complications are not unusual with Reboa placement. The important findings we can take away from this is that having a complication does not appear to be associated with limb loss or mortality. It is also important to remember that, as with any critically injured patient, that addressing complications promptly and working closely with our trauma surgeon counterparts is essential in optimizing outcomes in these patients.
That's an excellent series, and clearly Reboa is used in catastrophic injuries and trying to avoid a desperate outcome. I have a couple questions while we wait for anyone to come to the microphone. The first is, aortic occlusion through Reboa is generally used in extremely high-risk cases, and given that vascular complications wouldn't be detected in the large cohort you mentioned that died, do you think 12% underestimates the overall incidence of vascular complications? And then Number two, given the robust nature of the data here and the institutional policies, will there be any type of educational process for those that are typically placing these devices from the vascular division to improve those outcomes?
Yes, sir. So actually, within the last year, the trauma department did start implementing educational sessions with the residents and the fellows on ROBOA insertion. So hopefully, over the next couple of years, we'll be able to look at that data and see if that's had any positive outcomes.
Excellent presentation. I was just curious if you had any information on the prior number of femoral artery cannulations performed by the individual operators in these cases. What's people's usual experience prior to inserting the ROBOA for the first time?
Of course. So that was something that we were hoping to look at. And unfortunately, since it was a retrospective study, the documentation was very poor. Some of them were documented that they had multiple attempts, but for the most part, you didn't really know.
Okay.
Same for central lines and whatever. So I think if you don't ever teach it, you can't expect in emergencies and hypertensive patients not to get injuries. So, I mean, if you saved a life and had to fix a femoral endarterectomy, do a femoral endarterectomy, it's probably worth it. The question is, does the ROBOA actually save life? And that's a whole nother conversation.
Yes, sir.
All right.
Thank you.
Thank you.
So we'll move on to outcomes of staged repairs of complex endovascular repairs of pararenal and thoracoabdominal aortic aneurysms. Dr. Thomas O'Donnell.
Thank you. No disclosures. Thoracoabdominal aortic aneurysms are one of the greatest challenges facing modern vascular surgeons, with substantial morbidity and mortality, most notably spinal cord ischemia, which can affect up to 20% of patients. Endovascular treatments may reduce spinal cord ischemia by splitting the repair into stages to allow for collateralization and to dilute the physiologic stress of any one operation. However, data on this are mixed, most notably on the number of patients who drop out in between stages. We therefore use the VQI to study endovascular repairs of thoracoabdominal aneurysms using propensity weighting. There was a planned subgroup analysis looking only at elective extensive TAAAs. Our outcomes are shown above. Of note, tail or thoracoabdominal life-altering events is a composite endpoint consisting of death, permanent paralysis, stroke, or permanent dialysis. The VQI allows for the logging of stage procedures in two ways, either each procedure separately, in which case we have data on complications from their first stage, or all stages logged under one ID. For those patients, we only have mortality data from the first stage. There were over 3,000 repairs during the study period. 26% were staged overall, and 44% of the extensive aneurysms were staged. Staged patients were younger, more females and minorities, with higher rates of cardiopulmonary diseases but lower renal disease. Aneurysms treated in one stage were larger in diameter but less extensive and with lower rates of prior aortic surgery. PMEGs were the dominant repair type for both types, but most parallel grafts were done in one stage. There are almost 400 patients with data available for the first stage with complications shown here. When you factor these complications in, the overall complication rate of stage procedures increases by over 33% than if only the final stages were included. In addition, 25% of these stage patients are alive at least 1 year out from their first stage and still have not undergone their final stage. Single-stage cases took slightly longer with more fluoro time. In crude analysis, stage cases were associated with similar rates of perioperative death, but higher rates of tail, SCI, and stroke. However, after adjustment, there was no significant difference in any of these perioperative outcomes studied. Adjusted midterm survival was similar as well. The results in the subgroup of only elective extensive TAAAs mirrored that of the overall cohort, with no difference between stage and unstaged cases in crude or adjusted analysis. Medium-term survival was also similar. So in conclusion, staged endovascular treatment of thoracoabdominal aortic aneurysms was associated with similar perioperative and medium-term complications to single-stage treatment. However, first-stage procedures are associated with significant morbidity and mortality, and 1/4 of patients never complete their repairs. These data demonstrate the necessity of evaluating the outcomes of all patients planned for stage procedures, not only those who make it to the final stage. More data are clearly needed as to the optimal method of spinal cord protection for these challenging aneurysms. Thank you.
I had a question from your abstract, actually. You mentioned that first-stage TVARs carry significant morbidity and failure to progress to a second stage. Do you have any data on the length of coverage for those procedures?
We haven't broken that down, Gren, in terms of looking exactly what the length of coverage is. For most of these, it tended to be a zone 3 to zone 5 coverage, but we haven't broken it down in terms of the mortality related to that length of coverage.
Along the same lines, I think it was a 5.1% spinal cord ischemia with the TVAR. What was the instance of spinal cord ischemia in the other stage strategy, meaning, the branch?
In
When you stage, if it was staged.
in like a temporary sac perfuser.
Right.
So that's a little bit difficult to tell with the VQI. The VQI is a little bit difficult in terms of staging for temporary sac perfusers and things like that, because that technically comes as a reintervention usually from the first procedure. So it's a little bit difficult to tell. The branch staged variable is a little bit poorly done, and so unfortunately we're not able to break up in terms of methods of staging and their spinal cord risk.
Dr. Timur.
Yeah, it's counterintuitive to what we see just with purely endovascular procedures, because normally the first TVAR is really benign. The large multi-center study from the international consortium that was published not long ago showed that actually staging does decrease, morbidity, mortality. And normally the first procedure is very benign. I guess you're in the first group, in the first stage, you're also including some open procedures, right? Some hybrid repairs.
No, this is only for completely endovascular. So staged hybrid procedures were excluded from this cohort, and so I think that was one of the reasons that we did this, was because the general thought was that this first stage was benign, but I think the more data that comes out shows that it's not. So in that multi-center trial that was just published, only one of the sites actually recorded interstage mortality, and at that site 14% of their patients didn't go on to the second stage. The rest of that cohort was uncaptured, so we only have data on the final stage. And so recently, I think it was at the Midwestern, Dr. DiMartino published their results with their first stages, and so they had like 142 patients who were planned for staged thoracos. 20 of the 142 just didn't progress to the second stage, and 16 had major aortic events in between. So it's 37% or so of the cohort either had a major event in between stages or just didn't progress to the second stage. So I think that was part of the impetus of doing this, is trying to look a little bit more at that first stage, because I think it's not quite as benign as we used to think. And I think studying those patients to see who's not going to progress so we can better predict that, and who's going to have an interval event in between, I think is important to pick what is the right method of staging, who are the right people to stage, and who are the ones that are just not going to be able to tolerate the full, complete repair.
Yeah, that's very interesting, because that's not what we're seeing, at least in our center or in the Aortic Research Consortium. Be nice to see what's going on with the, VQI data.
Yeah.
Yeah, I think the bias is selection, right? I mean, if you are really thoughtful and plan, I think that's maybe why you don't see it, because it's an IDE and everyone's got to go through a very careful selection process. You probably eliminate some of those people from even being included. I think if you put all comers in and you don't be really thoughtful about that, planning the staging, because, in our Valiant experience, everyone made it to the second stage. And actually, on the people that I left like a celiac limb open, everyone made it for that second component stage, and there were no events. But I think if you don't plan well, and then you're going to have some people who are super high risk who just don't come back, and any small event might stop them from coming back to the harder operation. So depending how you stage it, but putting in a TVAR should really not be a high-risk procedure.
Yeah, I think it's, and like I said, that's the common perception, but unfortunately the data so far don't bear that out. And so it definitely does have a little bit more morbidity and mortality than we probably previously thought.
One final question, then we'll move on to the last paper of the session. It's a great series. You mentioned 25% had not presented for follow-up in terms of staging after 1 year. Earlier in the presentation, you mentioned that if primary stage complications were included, the overall complication rate rose sharply. Is it fair to assume that those patients haven't followed up if a stage procedure is planned? It seems like it most likely is a sophisticated medical center with intact follow-up programs. Is it fair to assume that those patients may have had more complicated presentations to begin with, or higher complication rate than those that did receive the second stage, and that's why they haven't had their second stage done yet?
Yeah, actually, if you look at those 25%, there's a good amount of them that just didn't have a complication, at least not in the perioperative period that we can see. So there's definitely, two populations who don't progress through the stages. There's those that have a complication, they don't progress, and then there's those that, just having a TVAR may have unmasked some amount of frailty that the surgeon didn't sort of recognize initially. They may have limped along afterwards and things like that and just never progressed to the second stage. So I think that's an important cohort that we need to study a little bit better to figure out who are those people who, just shouldn't get anything.
Great, thank you. Finally, we'll hear from Dr. Colon from UT Southwestern with a paper entitled Effects of Thoracoabdominal Aortic Aneurysm Height Index on Midterm Survival After Fenestrated and Branched Endovascular Aortic Repair.
Thank you for the Society for the opportunity to present. My name is Jesus Porras Colon. This is our disclosures. Well, as you know, the size criteria for thoracoabdominal aneurysm is not as clear as for infrarenal. The reason is that we don't have as clear evidence for support that. Aortic height index has been widely studied mostly in ascending and root aneurysms. For that reason, recently the American Heart Association guideline include that in patients who are significantly shorter or taller than average, this kind of index helps a lot. And they also point out that nomograms, according age, sex, and height, assist to determine the degree at which the diameter deviates from the normal in the general population. I said that we developed this project about using the VQI database in patients who underwent endovascular repair for thoracoabdominals, including 3 groups based on aortic height index. And the main goal was using Cox and survival models to determine the impact of the aortic height index. And we wanted to set up a AHI cutoff determined by a ROC court. We had 1,275 patients who underwent FEVAR for thoracoabdominal repair. Most of them were type 2 thoracos. The differences, the main one was the main aortic diameter in the third group. And also we identified that the third group had worse survival and worse 30-day mortality. As you see here in the Kaplan-Meier, as greater the AHI is, as worse the survival. We saw that also in the death-related, and we determined with the Cox analysis that dialysis, COPD, and symptomatic status were related with reduced survival. Also, we did a comparison with the diameter and the aortic height index, finding that the optimal aortic height index for thoracoabdominal repair was less than 3.5. And we determined that in our cohort, only 46% of the patients meet that threshold. And also, we saw that aortic height index was slightly better than diameter alone. this normogram helps to, individualize the patient decision. As a conclusion, there is a negative association between the aortic height index and the midterm survival after fenestrated endovascular repair for thoracoabdominal repair. And the threshold that we identified in the VQI dataset was more than 3.5. Only 46% of the patients met this threshold. And it seems that aortic height index is a better estimator of mortality than the aortic diameter alone in both men and women. But this obviously needs further research. Thank you so much for the opportunity.
Thank you, Dr. Cologne. Certainly interesting results there. I'll ask a couple questions while we wait for the crowd to come up to the microphones. Firstly, I think that a lot of this emphasis on body habitus and height originated from studies in the cardiac literature about BMI and safety for sternotomy and cardiopulmonary bypass-based procedures. And the height, I think, came a lot, as you presented, but also from connective tissue disorder patients who are usually have abnormal ratios in that respect. I know that you excluded connective tissue disorder patients here, but if you're assessing this as a large cohort, can you comment on why those patients were excluded?
We exclude those patients because we wanted to assess the general population with the height, and we choose the height because you know that there's some research about with the BMI, and we thought, like reading all the prior literature, that the height was a better estimator than the BMI, and we didn't want to have patients with connective tissue disorders that you can argue that they're gonna be taller and that is gonna affect or be biased. That's why we exclude them.
Thank you. And one other one, now that you have this data from such a large cohort across the country, have you started to approach your patient population differently on presentation in the office? Or do you have plans to do that, or is it still in evolution?
So I gotta tell you, the idea to doing this was when we were in clinic with Dr. Trimmer, he also, a lot of times he asked me, what is the height? What is the height? And then we were reading with Dr. Rahman on this. We also presented last year in the European Society of Vascular Surgery our research only in descending. And we have been using this in patients. It's not for all patients. I think that this is for individualized the decision in patients that maybe are not in the general population. Like for example, if you see the average of height in the U.S. for a male is 5'9". So what happens, for example, if you have a patient that is like 6'4", and you have a 5.5 centimeter aneurysm, so that maybe could affect your decision. Or the other, like for example, you have a female that is less than the average. The average of the females in the U.S. is 5'4". So let's say that she is 5, and then let's say that she has a 4.3 aneurysm. So that is why the normogram is really nice, because with the normogram you can assess the risk and say, well, maybe she needs the repair right now and not wait until 5. Or the other reason, maybe he's tall, he doesn't have a genetic disease, maybe we can wait for his repair. But the goal of this is individualize the decision of the patient. That is the goal.
Great, thank you. Dr. Shuja?
Hi, very fascinating research. Do you really make a case for operating on women at a 5 centimeter AAA if they are of a shorter stature? Because what I get from your data is, even if you repair them, because these are all patients who underwent a successful FBWAR,
yes,
and the overall survival is still different based on the 3 different segments of population. So maybe this is a more representation of their overall cardiovascular health, and that operating on them earlier based on their height doesn't take away the survival gap.
Yeah, that is a fair question. as you know, BQI doesn't give us all the data that we need to determine that, and it's right. It could be related to the cardiac wellness of the patient. But in the other hand, like as I told you, like the main goal of this is individualize the patient and have more tools to make the decision, because we are making the decision based on data extrapolated from the infrarenal size with studies that are kind of old. So that's why we're kind of doing this type of research.
All right, thank you. That was an excellent presentation.
Thank you. Appreciate it.